enhancing coordination for the outcome. It will enhance the coordination of healthcare service. Strengthening eye care partnership through guidelines, formations and MOUs. Kuna MOUs kama ile tulisaini atenwe. Itasaidia sana kwa mambo ya vitu mingi. Strengthening eye technicians working group and have a representative of eye coordination in the CHMT. Efficient eye healthcare service provider. Ensuring continuous quality improvement of eye. That is in chapter 3 is what they are addressing in this policy. Enhancing high, objective 2 is enhancing high care financing in Bomet County. Strategies to ensure that the chief of this policy. Strategy, having a specific budget line. Strategy moja ni kuwa na budget, yenye ikikuja assembly kuna budget line ya hiyo kitu. Isipokuwa naye hakuna mahali tume done in Bomet. Hiyo ni one of the sustainability. You donor akitoka hii kitu itaendelea. Like recently when the donor give the state policy in any state report, uliona tuko na wale wanafanya kwa staff, wale walikuwa wanafanya wa HIV na hizo za TB na hizo zingine. That is enhancing resource mobilization for the health through new partnership. Na tunaanza tena tunaendelea. Increasing of resources mobilization through social health insurance fund. Like SHA now, tunajua vile tutafanya tena hiyo pesa ya SHA ifanye kazi in healthcare. In mobilizing the resident to enroll in SHIP. Tufanyie wa enroll kwa SHIP and SHA. So that we can know. You know, watu wengine hawajajua SHA iko mara mbili hii kitu. Kuna inaenda tofauti. Like the registered SHA wa Bomet, kama if you are 4,000. Sahi watu wanaro kwa kuja wachukue dawa facility kwa Bomet. Hiyo mambo ya, you understand, there is a challenge there kidogo. So Bomet tunapata exactly 75 shillings times the number of registered whatever. Atupati hiyo ingine. Ingawa hawajatengeneza tupate vizuri, lakini hiyo ndio tunataka in Bomet so that it can assist this mobilization of resources. Looking for the expansion of tariff under SHA for eye health. Unajua mtu mwingine amelipa once na anapotea. So ile pesa tunapata ni ile active SHA tariffs. When you amelipa na amepotea atulipwi. So making sure that our people understand that when your tariff is active, the county is receiving a lot of money through active tariffs. Nabidi understand hizo vitu. Juzi nilikuwa na present Nairobi, watu wengi wanashangaa hizo vitu nilijuaje. I know those things. Make sure sio mtu analipa kama umewekewa 450 unalipa 450 na unapotea unangojea ukue mgonjwa. So all those months yenye hujalipa hakuna kitu tuna gain hapo. So the active tariffs is when we get, yani wale wako kwa SHA kifungua tu hivi wanaona Bomet active tariff ni 2000 anatupatia 2000. Lakini registered ni 4000. 2000 the rest sio active tariffs tuna lose. You understand? So one of these things is lobbying for the expansion of the tariffs under SHA. Watu wakuwe active all the time in their tariffs. Afikiri umenipata? So those are the things that we want to increase in access of the eye care. Objective number 3 is improving high care service delivery in Bomet. Now, strategy to ensure that the achievement of this objective. Ni namna gani tutapata namna gani? Strategy yenye tumeweka is scale up inclusive and integrating strategies for managing of eye care. Tukue integrated so that we know the management, vile tutamanage vizuri. Enhancing the community awareness, vile tulikuwa nimesema, reducing burden of vision impair through delivery of integrations patient service. Vile nilikuwa nimesema mtu akiwa na mgonjwa ikiwekwa kwa system, tukue na system nzuri, tukue na tena coordination between our CFSP in any community health promoters na the facility, provide rehabilitative care for vision impaired through the providing of low vision service. Kama sasa unajua low vision service, kuna spectacles inatumia. Unajua saa zingine kulikuwa na my grandfather, chicho moja ilikuwa imeharibika. Kumbe the route ile struggle ya moja inafanya kwa sababu hakupata kitu yenye ita balance, ikamaliza ile nyingine. So kuna tena vitu kama hiyo yenye moja imeharibika lakini ingine ingepata support ingekaa for some years, lakini kwa sababu ya kutojua inaleta shida. So we want to strengthen those things, reducing the pattern of vision impairment, providing rehabilitative care for vision impaired through the provision of low vision service, vile nimesema, promote surgical outcomes monitoring and service quality assurance. Hii monitoring sasa, kama saa zingine niliona, sijui kama hii ni ile niliona mzee mmoja alifanywa operation akakuja kumbe alikuwa agusa akafanya mpaka ikaribika tena akarudi. Hani kuna monitoring ya patient vile after hiyo surgery they can hiyo mambo ya referral. Kama vile tuko na our policy ya kwa county kuangalia pressure nini muende hata hizo strengthen. Objective number 4 is strengthening the resource. Hii sasa ndio inabidi tuangalie kabisa human resource for the eye healthcare. Recruit adequate mambo ya madaktari wetu tupate ya kwamba tumerecruit ya kutosha. Continuous capacity building, tuwapatie tena waende shule. Vile nilisema kama kuna wanaenda shule, at least tukwe na watu wa macho wanaenda shule. Tusione tu sisi madaktari wengine wa ada wanaenda tunaacha hawa. Equitable distribution of eye care personnel in the facilities. Usiache mahali pengine unakosa kabisa mtu hapo. Kama wakati wa nutrition nilikuta kuna almost hospitali kama 3, yani almost a sub county hakuna mtu wa nutrition. So tunataka at least kuna distribution yenye inakuwa in every sub county. Tuko na watu wenye wanatusaidia kwa mambo ya eye care in facilities. Alafu expansion of staff establishments, hiyo ni kama tu hiyo. Alafu the continuous enhancing data tukue na eye unit in every level 3 and whatever. Alafu incorporate new technology innovation bridge. I think you have get the information and the objective of the policy and also how we have the policy. So the comments, I think you are noting. If there is anything, it is highly welcome for any amendment before we pass the policy on fast. It will be fast. Yeah. The assembly will sit and will present. The committee will make a report, of which I can make our report as the committee. So before I give some few people to give their views, let me welcome my colleague, maybe aseme jambo na mjue ni nani. Karibu mheshimiwa.
Thank you, Chairman. The honorable members that we are together here and the team that have come for the public participation. Good afternoon. My name is Eric Kirui, Chairman Budget, and I'm here for this public participation because we are all keen in supporting this policy, and I know today's public participation, I've met the chairman coming out and trying to explain to us what the policy entails, and I think I want to thank everyone who's participating here today. You've sat here patiently, just listening through, and I think of great importance is your inputs towards development of this policy. I know there are so many things that will always come up when you're doing a policy like this, and of course everyone else would want to see maybe it's a new thing that you're doing, but it is a step towards the eye health, and I know I know when the policy was being developed, there's the high health situation analysis that was done in Bomet County, and I think that's really very important. I'm actually very keen in trying to see how the technocrats would want to stratify the population in terms of the provided demographics, in terms of how you want to collect the data, or how you collect the data, who are of the old age. Geriatrics takes the eye issues, especially when people are beyond, after 70. I know people always have issues with their eyes, so it's also good to have a policy like this that will always address those ones. So mine is to just support, be able to in budget process, and even allocating the I don't want to say much because I am a bit under the weather today, so we will bear with one another as we support you guys in the public participation. So I'll hand over the mic to who's the Lele, you're the one who's coordinating our positions here? Yeah, thank you. We will be keen to listen to your inputs. Asante sana.
Welcome. I think the presentation of the policy has been done by the members, and the members are the ones to make the decision on this policy. They will also be able to consider your views and amend accordingly through the recommendation in a report writing that they are going to do. Probably before the opportunity now is presented to you, I would wish to invite the legal officer for a minute to give us an overview, the threshold of the policy, and I want to thank the chair for having taken us through the whole process. So I think, Calvin, I don't know whether you have anything on anything that you think. Thank you.
Okay, thank you, Lele. And I want to thank each and every one of you for staying up to this time while trying to enrich this policy. The chairman has sufficiently gone through the policy, and what remains now, of course, is we want to get your views on the same. It's a constitutional imperative under Article 196 of the Constitution for the County Assembly before passing or but then as an assembly, we assume that public participation has been done now county-wide. That's why we are doing it only here. We just want to confirm based on the information that we are going to get from the members of the public. So of course, if it were not for resources also, we would have gone down to the ward level, and because that is a requirement of the law. But currently, based on budget constraints and of course financial, we know currently that the economic situation of training in the country is not very good. That's why we have tried to at least to comply with the Constitution. So what we would expect from you, of course, now is
continue some collection, and specifically on this policy, so that we can prevent this kind of disability, particularly in health. And they become advocates of personnel.
So that we are saying 56%, for example, of there are 1.7% of people with blindness in Bomet are suffering with cataract. But then we need information. You see, that information needs to be backed up by data from Bomet. From Bomet. Say, for example, tell on this instance, one person could read the policy, and that is why you see some people making comment and say we could instead have a policy on cancer, because cancer, people know cancer, see you? Yeah, in fact, you do not need a rationale to have a policy for cancer, because you know. But now for this one, for I, we know the importance of having a high policy, but then that needs to be justified for the readers, and even to attract some financiers. Number two is the issues of quantifiability. And this is something that I think we'll have a discussion, Chairman, with the department on even the implementation. If you see the implementation matrix and the objectives, let us leave the objectives. If you say, for example, 56% of the people in Bomet, or 56% of 1.7% people who have, or of course, you are saying 56% of the people are suffering, have cataract, out of the 1.7% of course of blindness. That is the base data. That is the base data. That is the baseline data that we are working on. So it is from this information that in our implementation matrix, that is implementation matrix, what we are missing is what we call the baseline data. If you are saying, for example, we need to make sure that we need to eradicate the issues of cataract from 56, it's 6%. So we should have the data. That is the baseline. Nasema kwamba 56% of those 56% of people are suffering from cataract. But then the policy now should say, out of time, we are intending to reduce that to 6 to say 10 or 5%. So that's why I'm saying I think we still propose later that every aspect of the objective that has been mentioned in the implementation matrix must be quantifiable. If you are saying, and it's good, I heard someone say, like this gentleman who mentioned something about the screening. That's why he was saying, let us be very categorical on the screening. Let us not say regular. How many screenings should we need? If, for example, and we must have the baseline, let's say at this point in time in 2025, how many screenings are we doing? Let's say we are doing 0. But then in the midterm, or in the lifetime of this policy, let's say by 2030, we are supposed to do maybe like 1,000 screenings. That is how now we can now track and trace the success of this policy. And that is why it is our view, it is our humble view, that when as we go forward, because this is a policy that is still work in progress, we are proposing that every aspect of the objective, particularly those that have been assigned to be implemented in the implementation matrix, must be backed by, first of all, the baseline data. How tukoaje in 2025, tukoaje in those things, kwa cataract, tukoaje kwa sensitization, tukoaje kwa all those other things, all right? And it is out of that now we can now have an implementation matrix that will even guide us in reduction. I was seeing Madam Daktari, I was seeing the cancer policy. In fact, the very exciting thing is the cervical cancer. It is very exciting in Kenya. And I think this is a conversation that we need to eradicate. In Libya and the Islamic, and you need to check, in the Islamic nations, and I was seeing one for Libya, vis-a-vis Kenya. In Libya, in 2019, they reported 130 cases of cervical cancer. Those who died out of cervical cancer in Libya in 2019 are 130. The women who are using protection in high sex, there are no data, it's 0. So it means they are not having PAPs. So the Islam. Come to Kenya in 2019. In 2019, we had 3,400 deaths out of Nini. Those who are using protection, the women who are using protection as a result of cervical cancer and so forth, we are at 44%. So there's a lot of conversation that we need, and I heard Chairman saying, there was a lot of, the reason why people, even our women, in fact, the reason why even my sister refused to go for vaccination is because church interfered. Catholic Church was the first one to go interfere and say, this vaccination will lead to what? To infertility. Yeah? And even in my church, I heard a pastor saying, Musiende. So those are the things that we are supposed to fight. Now, forgive me for digressing. I was seeing the cancer policy for Kenya, and it is there. For cancer policy, they are saying, and that is why we need to be very clear in solutions. They are saying in the implementation, they know that, for example, the major cause of cancer is tobacco, smoking. And in the implementation matrix, you will check, they are saying the baseline is that 10% of the people, 10% of the population in Kenya are smoking. All right? And they are saying in midterm review, that is in 2024, they are saying we need to reduce that to 7%. In the lifetime of that policy, cancer policy, they are saying we ought to reduce it by 2%. Yeah, the 2% of the population of Kenya should not be smoking by 2030. And that is what, because that is the major cause. When they come to the next thing, screening for mammography, they are saying 1% of the women have been screened. 1% of 28 million women in Kenya have been screened for mammography. 1%. But then they are saying in the lifetime policy, they are not well ambitious. They are saying we want to do 30%. 30% of the women by 2030 should be screened for mammography. And it is against that we are saying, therefore, that please, because this is a working thing, so that we do not deal with adjectives that we are saying regular, nini, we must deal with real numbers. If we are saying, for example, you want to do screening for schools or because, and that is something that also we are recommending that this eye policy, in fact, Wanachama, the screening has not been, you see, the major thing, in fact, in our reading is that if you screen at school, if you do the screening at early age, wakati tu wako primary, between maybe grade, the early primary to start, if you do screening at that point, in fact, you are sure you will eradicate 90% of the cause of blindness. So those are the screening that you are supposed now to see, map out and know the number of primary schools in Bomet and say we are targeting to screen this by year so that at least they are traceable. Then number two, Wanachama, is the emphasis. The major cause of blindness in Bomet is cataract. In fact, if we do today, in fact, hakuna pahali imesema kwa policy that we intend to do this number of surgeries, high cataract. And that is very important. You know, we are supposed to say by 2030, because let's say this policy is 10 years. So we are supposed to be very specific and say, because we have money and because there's not money and because we are saying that we are supposed to say at least we are supposed to make sure that we do even 1,000 surgeries of cataract per year in Bomet. And so that by the lifetime of this, you know that it is out of those surgeries that you reduce now the proportion for Nini. And then last, the chairman, so that I don't talk too much, is the issue of finances. This policy is seeking to harness resources, of course, it's a resource mobilization tool, all right? In fact, there is a part that they are saying part of this policy is to resource mobilize. Now, if you check even for the national, the one I was reading for cancer, it's very exciting. I don't know why I chose. Right now, or in 2019, when they are developing this, they are saying the amount of money that was allocated to cancer was 0.5% of the total budget of health. That is by the time, that's why they developed that policy. They say, Wanachama, 0.5% of the money ambayo ilikuwa allocated to cancer kwa Kenya ni 0.5%. And their target is that we want to make sure that by the end of that policy, 30% of the money is allocated to cancer. And that is why we also want in this policy, because here takusaidia chama, we must work on a proportion. Sahizi, if you do 5 million is allocated sahi. 5 million sahi kwa hii CSF. In fact, kwa hii budget yenye tuna it's zero. So that's the baseline. Kwa CFSP, they are proposed to allocate 5 million. If you do the proportion of that 5 million vis-a-vis the Department of Health, health is doing around 700 million. 5% of that 5 billion over 700 is a small amount. So that's why we are saying it is good to work with figures when you want money. So that we are saying in the long time, or maybe next year, or maybe in midterm, hii policy, tuseme ya kwamba pesa za high, it should be around maybe 20% of the total of the budget. So that when akina chairman are making budget, there is a proposal, let's say for 30 million for I. Wanaulizwa mbona hii pesa imeulizwa, sema it is in the policy. It is in the implementation matrix. The implementation matrix say that we need to progressively allocate 5%, 10%, 20%, to even 30% of the department's budget for what? For I, so that we can now achieve. Lakini when we just put a blanket figure that we need to progressively increase the allocation, even they can increase by 5.5 million next year, but it's an addition. It's a deal. But then we must be very careful. So that is a conversation that we are pushing. I hope the department will agree with some of these comments that we need to have a quantifiable matrix, reduce it to watches of literature, reduce it, make it so that it was something that even we can track. Even we can track when we say tumefanya nini, and I think. But nonetheless, this is a very good policy, and those are our few comments, Chairman. I think at later stage we can still have a discussion between the committee and the department so that we can harness. Perhaps also we are talking from some perspective of ignorance. But then we are saying maybe we can. It is out of those discussions that maybe we can be brought on board on some things. Otherwise, thank you very much, Chairman.
Thank you. He's our researcher. That is why we have in the technical team. He's doing a research in the assembly on many issues. And he has been assisting us in doing research. So naona anajua policies zote. Before I give to one of us, I think for that one of how we have come along, we have records. Like now, Longisa, even I'm very happy that now we are doing some surgery of around 20 something by now. So we have some records on the same. The only thing is that percentage of the budget. But the other one is, that one we have. We just only something to offload. Let me give to my friend here.
Thank you so much, Chair. Thank you very much for the contributions. I'm very happy about, you don't say his name, we are just told that he's a researcher, Timothy. We are very grateful for these comments. And our Chair, we can assure you that probably when we were having our sit-downs, doing all this research and collecting data, we even went through the cancer policy. What we didn't do at that particular point is that we didn't merge the policy with the strategic plan. And now, as you realize that, even when we were with you last week, what we were doing is that now we have a policy, but then it is accompanied by a strategic plan, which has what we call the baseline, which we have midterm, we have even end term. We were advised again by the county assembly that for this particular moment, we've never had a policy at the county. Even countrywide, we don't have an I policy. So what do we need to do? We need to have a document which forms a baseline. Then immediately we get this policy up and running, we accompany it by a strategic plan. And our mandate in the strategic plan elapsed yesterday. And we can report that we did submit a strategic plan to the CEC. And I'm sure by Friday or next week, that strategic plan is coming to the Assembly. Thank you so much.
When we were in Kisumu, we went through the strategic plan, of which it was a very nice strategic plan, of which we have the records. We have the records of how this the diseases gone up, and now the one achievement that we had since we started with CPM, of which my colleagues here, the implementation side can give attest to that, is people first attend to hospital. The numbers. Tulipata namba mingi wanakuja hospitali, of which hawakuwa wanakuja. So we get a very good number and you attend hospital first for checkup.
Okay, just to say something about the quantifiable data you said. The RAP study was done nationally, but it was done in the specific counties. So when we call the RAP study, it's Bomet data. That survey was done in Bomet. And it's published, you can access online. Secondly, we've also quoted the VIP data. When you say VIP, it's Visual Impact Project. It's a project implemented by CBM through TENWEC in partnership with the county. they did screening in all the community, door to door. They also did screening in school screenings in all the schools in Bomet. And there was treatment outreach, and also there was also treatment at Longisa and Tenwek. So we have that data. There is data, VIP data. When we quote VIP data, it's real data. Thank you.
Okay, Chairman, so it is maybe a proposal that maybe we can flow to this.
I think my idea is that, I think that RAP study is not quite questionable. In fact, I look at the study. The respondents, I was wondering, they interviewed 4,928 people. In fact, there was a response of around 93.3%. It means many people turned out. But then I said, was this really, you see, that survey, they came and surveyed around 4,000 people in Bomet. But then, was that survey, what was that survey? And it was random, So, random, so you see, it's not good by those data, in fact, when you check their website, of course, there are many countries, you can study. But you see, we are talking about now Bomet. We are talking about Bomet and justification rationale of having this policy. Rationale, that is why people are saying, you need to prove to people that even we can have this policy. You haven't said, like for example in Longisa, this is the total number of patients that we receive. This is the total number of patients that we receive cumulative. Out of these are the ones that goes to eye clinic. These are the breakdown of the eye clinic. These are, of course, there is the charts, kuna treatment. Those empirical data. That's why I was saying empirical data is yes, so that you tell a story, so that any person when atasoma this policy when atoke Bomet, when ako US adona, anaona kweli kumbe there is a problem in Bomet. You see, tumeenda global, if you see Chairman on rationale, we've gone to global, and then we've gone to Kenya context, Africa, Kenya, alafu Bomet iko na that rap stadium kidogo, a paragraph. And that is an opportunity for you to shine. Unajua umepewa kushine to a data yote, even ask the data. In fact, we were discussing with my director. Even it's very lucky that we have a combined. Even we can Tenwek. You are saying even Tenwek go. Tenwek can give you very rich data, empirical data. Out of Tenwek, out of Kaplong, and then you shine. Alafu mtu kweli atasema kweli, kumbe this thing is really warranted in Bomet, and that will inform even pesa. Wakati Jamhuri ataomba pesa kwa budget, atasema so unaona kuna shida. Unaona. The issue that came out very clearly in the policy is the issue of recruitment personnel. That came out more than any other thing. Ya kwamba kuna shortages. But then again, that is why I was saying we'll discuss this. But then again, kwa matrix, ambuku sema, unajua unafaa kusema unataka kuajiri ngapi? Kuna pale umesema unataka kuajiri ngapi? Strategic plan, sio? But then we were not private with strategic plan. That's why some of the data we can borrow some data here. We can improve on this so that the strategic plan can be equal the basis, so that I think that is but nonetheless, thank you.
I think wacha aseme kwa sababu hiyo iko na tulipitia hiyo yote unasema tulipitia, the only that hayuko kwa.
Thank you, Timothy. I think for the data for what has been happening in Bomet, I can assure you we have it. In fact, we have the data for screening the whole population for the last 3 years. We have the results of the screening per sub-county, even per facility. That one will just lift from our information and put in the policy. Yes, I want to clarify that. Even for the HR, if you look at our strategic plan, each and every objective of the policy has the baseline. It also has in terms of numbers, where we are dealing with proportions, we have percentages, even for the funding. Even HR, there's an M&D framework which takes care of all the objectives, and that's the baselines. Maybe we'll also have a sitting and we'll share the same. Thank you.
I was seeing, okay, you can maybe have Madam to raise something before.
Thank you so much, Chair. I think one of us, and
especially now it's our first document that you say it's our first policy. I think, as I said, most of them has been dealt with by Timothy, especially on the issue of the problem, the clear problem, why you need to have this policy. That one you've captured it very well. And the issue of budget, the financial sustainability, looking at the objective of the outcome is not matching exactly why you really need to have that sustainability for funding. So probably you also need to, I do not want to mention much because we have a write-up that we will share with the committee, and I think subsequently they will also share with you so that we all amend this document and have it in the format that you all want, or that will all help us. We were also looking at probably the public awareness. Someone said that we need this document to promote health promoters than the curative. So I think we need to put emphasis on the awareness. And there is somewhere you also mentioned the stakeholders, but ukiona kwa matrix, the actors, you don't place this, so probably to see in the areas so that you also see it. And then, yeah, I think that is on the same. So, Chairman, I think at a later level we will submit our write-up so that the committee will deliver it on the same. Thank you.
Thank you, Chairman. In fact, what Madam has said is what I was to propose. Timothy gave us a very rich prompting. I desired that we get the write-up because it would enrich the document, because this is our document. And from a research point of view, I think that is one of the areas we will need moving forward. Of course, Timothy, moving away from data, then the question of research is still a gap. Because if we still rely on to inform our local issues, problem, engage partners in research. And that is what the document, the policy, go to the research bit as part of your keen interest so that you can critique whether we captured it well. Also, it is in the write-up. Very grateful, we'll be very grateful. Because you discover that engaging a research away from reports from the hospital, away from data, away from the tools that are in the M&D department is quite expensive. And maybe sometimes you'll need a donor to support that. Like RAB is supported nationally by a number of partners. So area I thought we really engage. These are document and